lecture. Parang hinahabol natin, parang nagbabike siya eh. Anyway, the third speaker will talk on the recent advances in new anesthesia management of the subarachnoid hemorrhage. And I'd like to present Dr. Geraldine Jose.
Thank you very much for coming over and listening to the series of neuroanesthesia updates. And of course, we would like to invite you to the ASNAC-ASCA meeting this coming 2021. This has been something that we have been working on for the past couple of years. We had to bid for this in both Asian societies in two different venues, and of course we had to prove our worth as Filipinos to bring this here in the Philippines. Okay, and just the fact that bringing both societies here in the Philippines at the same time was also another challenge that we had to face with the leadership of the Philippine Society of Cardiovascular Anesthesia. But then again, fortunately, they granted this to us, and so we're very excited to showcase what we can offer to Asia. So hopefully we can see you there. We have actually prepared, started coming up with a program which will be both interesting for both practicing anesthesiologists, regardless of whether you are a neuroanesthesiologist or a cardiac anesthesiologist at that. Okay? Because what we intend to do here is for every symposium, there will be a multidisciplinary approach to it, meaning we'll be inviting surgeons, crit care specialists, and the practicing anesthesiologists for that particular cases, so that we will have an in-depth and more multifaceted approach to the management of our patients. So that's what we are working on right now. Okay, so my topic this afternoon is the recent advances in the management of subarachnoid hemorrhage. So the learning objectives are to understand the natural history of subarachnoid hemorrhage, to know the grading severity of subarachnoid hemorrhage, to familiarize with the current critical care management of patients with subarachnoid hemorrhage, and to reorient our goals in the anesthetic management of subarachnoid hemorrhage. What we need to understand is that subarachnoid hemorrhage doesn't only happen in cases of ruptured aneurysms. You need to understand that the cause of subarachnoid hemorrhage may vary. It's not only in cerebral aneurysm rupture. Okay? So we'll tackle that in a while so that we'll have a better understanding of how we are supposed to manage our patients. So the common causes of subarachnoid hemorrhage are trauma, ruptured intracranial aneurysm, bleeding from vascular malformations, extension from parenchymal hematoma, perimesencephalic hemorrhage, and others. So trauma is the most common cause. It tends to have a peripheral distribution in sulci rather than concentrated in the basal cisterns. And that you'll see on the CT scan. When you see the scan, you find that the hemorrhage is in the parenchyma. It's most likely be trauma, brought about by trauma, rather than by a ruptured cerebral aneurysm. Okay? For ruptured intracranial aneurysm, it is the most common cause for non-traumatic subarachnoid hemorrhage. It may be potentially devastating condition with 50% immediate mortality and high long-term morbidity. So this is just an example of a traumatic subarachnoid hemorrhage. Picture is not too clear, but the hemorrhage can be found in the convexity of the brain. Other causes of subarachnoid hemorrhage could be bleeding from vascular malformation. It can be cerebral or it can be spinal. It's around 5% in incidence. And extension from parenchymal hematoma, often due to a hypertensive bleed. The incidence is around 5% also. There is also a perimesencephalic hemorrhage that may be interpreted as a subarachnoid hemorrhage. They may be due to low pressure probable venous hemorrhages. There are few symptoms and signs, but they are good prognosis. Other causes may be the use of anticoagulants and also vasculopathies. So this is what we're familiar with in terms of how a cerebral aneurysm appears. It can be berry in shape or it can be fusiform in shape. Most of these berry aneurysms are located at the bifurcation of in the circle of Willis, okay? And the fusiform shaped aneurysms are usually in the basilar artery and the vertebral arteries. Saccular aneurysms occur at the bifurcation of large and medium-sized intracranial arteries, okay? And the rupture is into the subarachnoid space, in the basal cisterns, and often to the parenchyma of the adjacent brain. Approximately 85% of aneurysms occur in the anterior circulation, mostly of the circle of Willis. So only 15% are actually coming from the posterior circulation, okay? So about 20% of patients may have multiple aneurysms and may actually be present and mirror and be present in a way that they are actually in sites that mirror each other. In short, bilaterally. So these are just the common sites of a berry cerebral aneurysm, as seen in this picture. Okay. So when the patient goes through autopsy and through angiographic studies, they have found that about 2% of adults harbor intracranial aneurysms. They may not rupture during their lifetime, and the size may be just 2 millimeters to 2.3 centimeters average to 3 millimeter average, and the average size is around 7.5 millimeters. Those which rupture are usually 10 millimeters in size or more, but smaller ones can also get ruptured. Okay? They are of different shapes and forms, as I've mentioned earlier. And these berry aneurysms, they actually have a narrow stalk. Okay? Some others may be broad-based, like a fusiform shape without a stalk, and some may just be cylindrical in form. So one theory is that they result from a developmental defect in the media and the elastic layers of the vessel wall. Other theory says that aneurysmal processes is initiated by the focal destruction of the internal elastic membrane caused by the hemodynamic forces acting at the bifurcation and branching of arteries. As a result, this leads to weakening of the wall, particularly the intima, leading to bulging out the surface, forming a sac. So when you say giant aneurysms, they're actually greater than 2.5 cm in diameter. It accounts for around 5% of cases, and the three most common sites are the terminal internal carotid artery, the middle cerebral artery bifurcation, and on top of the basilar artery. The risk of rupture is around 6% in the first year after identification and may remain high indefinitely. They often cause symptoms by compressing the adjacent brain or cranial nerves. In terms of pathophysiology, aneurysms are seldom actually seen in children on autopsy, and so subarachnoid hemorrhage in children is actually quite rare. Okay? So what is the clinical manifestation? Most unruptured intracranial aneurysms are completely asymptomatic. Aneurysms can undergo small ruptures and leaks of blood into the subarachnoid space, so-called sentinel bleeds. Symptoms are usually due to rupture and resultant subarachnoid hemorrhage per se, although some present with mass effects on cranial nerves or brain parenchyma. In 45% of cases, there's severe headache associated with exertion, and this is usually the presenting complaint, and they usually complain that this is the worst headache of their life. Okay, however, the most important characteristic is the